Hello, my name is Robert Curtis. I'm one of the sleep fellows at the Henry Ford Sleep Center, and we put together a QI project in regards to obesity hypoventilation with the hopes to increase the detection in an outpatient setting. So there I have the definition of OHS there up top. I think it's important to note that OHS is a diagnosis of exclusion, and because of that, I think that's one of the main reasons OHS remains significantly underdetected in an outpatient setting. We have no patient, general population-based studies to kind of get us a true prevalence. But current estimates, have the general population prevalence at about 0.2% to 0.6%. And the epidemic of obesity is worsening every year, which we can suspect that OHS incidence is also increasing along with that. So why we care, we know OHS has worse morbidity, worse mortality. It actually has worse quality of life too compared to obese matched patients as well as patients with matched severity of sleep apnea. These patients have higher rates of hospitalization, they're using up more resources, more healthcare dollars. It also takes a toll on their own bodies from a cardiorespiratory standpoint. Often these patients are recognized in the inpatient setting where these resources are readily available, ABGs, x-rays, etc. And we want to know if we can catch these patients earlier before they get to that, severe point. So we put together a project where we organized a clinic policy along with staff education to see if we can improve the detection of OHS in our outpatient settings. Our overall goal was really to evaluate if providers are more conscious of OHS. Are they more aware of it? Do we change orders? And we want to know, one of our smaller objectives was to see, what does this do in terms of sleep studies orders and immediate treatment thereafter, which we'll get into a little bit more detail. So our policy we put together is there on the bottom. Consider OHS and order an ABG in all new patients with a BMI of 50 or greater. So we just looked at new consults, new patients with no prior sleep study with a BMI of 50 or greater. And if they had a bicarb of 28 or higher or resting SpO2 of 92 or less, then we were to order an ABG and be concerned for OHS. We picked these numbers because we wanted really high suspicion. We wanted to increase specificity. And what we did is we did a chart review before the policy and we did a chart review after the policy to kind of compare the two groups to see if the policy implementation actually made a difference. And when you look at the demographics, they're pretty well matched. So I think we have, pretty good groups going into the evaluation, which I'll look at here next. Same number of total patients. The gender ratios look the same. BMI in terms of the severity of obesity going in was well matched too. Remember, these are all new consults with BMI of 50 or greater, so none of these patients had a BMI less than 50. So when we get to the nitty gritty here, here's the data points that we were actually looking at to see if we can make a difference. So that first one, OHS considered, we looked at the physician's notes. Did they document their thought process of obesity hypoventilation or hypoventilation? Were they more consciously aware of it? And we saw a big change after implementing the policy, almost twice as much with a very significant difference in those two. And they're also ordering more ABGs. So ABGs first ordered, that's that first office visit. ABGs ordered overall, that's anywhere after, including that first visit. We saw a huge statistically significant difference in the amount of ABG orders. But if you look at what the patients was actually obtaining, did they go get the ABGs? There was a big drop off in the amount, which I'll talk about here in a little bit. PFTs, there was no significant difference in the amount of PFTs ordered. Note that that was not part of the policy. I want to just include that there to see if the thought process and orders were changed elsewhere. And when you look at the type of study order, there was no difference in the type of study. We're ordering the same rates of HSTs versus NLabs. The AHIs were pretty comparable. No difference in those two in terms of averages, min, max, which shows that the severity of illness was pretty well matched between these two groups. And if you look at the immediate type of therapy started, there was no difference between bilevel and CPAP. And then when you look at patients with hypercapnia, so this is patients with a awake CO2 greater than 45 and either the ABG obtained that we ordered or an ABG prior within the last year. And there was no significant difference in that. So I think the policy and the education showed that we were, quote unquote, successful in making physicians more aware. They were more considerate of OHS. They were ordering more ABGs. So I think that has the potential to show an increase in the detection. The concern was, these patients actually weren't getting the ABGs. There was a disconnect and a bridge in terms of what was ordered and what was actually done. And I think we have to look at our system to kind of see what we can do to change that. There was also a lack of follow-up. Not all these patients were seen after the sleep study, which shows that it's difficult to kind of complete the whole process, seeing what they're doing at night in terms of ordering ABGs and diagnosing OHS. We saw that we can make a significant impact in the physician-patient encounter, but it wasn't changing the immediate after fact. We were ordering the same type of study. And I think a lot of that has to do with insurance. Insurance sometimes ties our hand in the type of study we order. Sometimes we can't do in labs. We're stuck doing, home sleep studies. Patients also have a preference. Sometimes they refuse to go to the in labs. They want to get their studies done at home, which plays a role. We didn't see a change in the type of PAP therapy started, in the short aftermath of a study. So a lot of that has to do with the actual study that's actually obtained. So if we are ordering the same amount of HSTs, it's hard to order a BiPAP right after an HST. If someone has sleep apnea, you actually have to start CPAP and they have to fail CPAP before you start BiPAP. So without actually getting in-lab titration split nights, it's very difficult to see if there's actually going to be a change in the type of therapy started in the immediate after fact. And insurance approval, plays a role too. We have to, jump through a lot of hoops to get these BiPAPs approved, and that's hard to do, in the short after fact, and sometimes can take a few months and several follow-up visits to kind of get everything teed away. And I think it's important to note that there's no studies that show a significant difference in terms of BiPAP superior to CPAP in patients with severe OSA as well as OHS, which a lot of these patients had severe OSA. So I think, further studies, things that, this QI project kind of opened doors and kind of saw some things that we could potentially change. We need to look at our system and do a system analysis in regards to patients' ability to attain ABGs. We're placing these orders. We need to look at why these patients aren't getting them and what we can do to actually, improve the rate of getting actual data from our orders. Further studies need to be done to show, does this policy and education actually change long-term outcomes? What are these patients on a year after? What's actually appropriate for them? Do we know if bi-level is actually better for these patients if they have severe obstructive sleep apnea? Nothing's really shown that yet, and further studies need to be done to see. So that's our study on obesity hyperventilation syndrome and trying to increase the detection. Thank you very much.